Hello, and welcome to the Liver Coalition's webinar tonight. My name is Terry Cunningham, and I'm the president of the board of directors for the Liver Coalition of San Diego. We have another informational seminar for you dealing with liver disease. Basically, this one will be about fatty liver disease, diabetes, and obesity. We have experts providing you very useful information. The Liver Coalition was founded last year to fill the void created during the early days of the pandemic. Now, all funds raised stay in San Diego and do not go to a national organization. Please check out our website for other webinars and information that will be useful. Thank you for attending, and I'm going to turn this now over to Scott Succo, our Executive Director. Hi, Scott.
Hey, Terry. Thanks so much. Welcome. I'm your Executive Director, Scott Succo. I'm glad to be here. Before we get started, I wanted to thank a number of our sponsors and industry partners. And a couple are here today with a message in person, and a couple have videos, and then I'm just going to recognize a couple as well. And collectively, they make this possible. With us tonight are Dynavax, and Dynavax has been an early sponsor of our webinar series starting last year. And so, Carl, thank you so much. I know you've got someone with you today that you want to introduce to the team.
Yes, thank you so much, Scott. It really is a pleasure to be a part of this webinar series. Greg Cohen is a vaccine specialist down here in San Diego, and it really is a pleasure for us at Dynavax to partner with the Liver Coalition of San Diego, because you do such great work in the community. At Dynavax, we are very, very focused on preventable diseases. We are the makers of the only 2-dose, 1-month hepatitis B vaccine. And what's important to note in this time of vaccines and being very aware of different viruses and diseases is that hepatitis B has no cure. So vaccination becomes extraordinarily important. And Heplisav, which is our 2-dose, 1-month hepatitis B vaccine, has some very interesting origins that relate to San Diego. So back 15 years ago, 4 scientists in a laboratory discovered this brand new adjuvant that is a very important part of this vaccine, which allows it to be completed over the course of just 1 month with very high seroprotection rates. And those 4 scientists were actually in a lab at the University of California, San Diego. So that happens to be where our speaker is from tonight. And thank you, Dr. Ajmera, for making time for this. And Scott, again, we so appreciate the Liver Coalition of San Diego. It really is a pleasure to be here, and I'll turn it back over to you.
Excellent. Welcome, Greg, and thank you so much, Carl. I want to thank our sponsors from Intercept, Exelexis, and ESI for supporting these webinar series as well. And we do have a couple of videos to show you. The first one is our partners from AbbVie. Great. Our next video is from our sponsors at ASI, and we'll hear this message from them. Excellent. Additionally, we'd like to thank our partners from Gilead for making this possible. As we go through the webinar, know that this is your opportunity to ask questions. In the chat box, there is a section where you can send questions. I'll be serving as your moderator tonight, so feel free to put your questions in there, and I'll make sure that they get addressed either at the time that you submit them, or I'll collect them and we'll ask them at the end with the presenter. Also, tonight's webinar is intended for educational purposes only. This is not intended for medical advice. For that, you should talk to your doctor, but do look at this as educational information, and we hope that you evaluate it as that. To get us moving, I want to introduce our presenter, Dr. Ajmera, who's with UCSD San Diego. He is with their NAFLD NASH Center there, and is an expert in fatty liver disease and NASH, and really is bringing together a lot of the topics, the intersection with obesity and diabetes, as we take a look at whole person health, and often individuals have more than one chronic health condition, which is the case in this disease. So Dr. Ajmera, welcome, and thank you for being here today, and we look forward to your presentation.
Thank you, Scott, Terry, and the Liver Coalition of San Diego for the opportunity to present on this topic. Are you able to see my screen?
Yes.
Yep.
Fantastic. Okay, great. So today we're going to review fatty liver disease, diabetes, and obesity. As Scott mentioned, I'm Veeral Ajmera. I'm a researcher at the Non-Alcoholic Fatty Liver Disease Research Center at the University of California, San Diego. I'm also the medical director of liver transplantation. And so today, as an outline for our talk, we're going to review what is fatty liver disease and who does it affect, what happens once you have fatty liver disease, should people with obesity or diabetes be screened for fatty liver disease, and how can I treat fatty liver disease? So what is fatty liver disease and who does it affect? Non-alcoholic fatty liver disease and alcohol-associated fatty liver disease both can present very similarly on a liver biopsy. The diagnosis is made when there's a pathologic or abnormal amount of fat in the liver. So the threshold is really more than 5% of the liver is occupied by fat. The liver shouldn't have this amount of fat, and there can be consequences of the accumulation of fat in the liver. Many things can cause the an abnormal amount of fat to develop in the liver, but the two most common causes are alcohol and non-alcoholic fatty liver disease, which is associated with weight gain, obesity, and diabetes. Once you have fat in the liver, there are two general forms that we see when we biopsy a liver or take a small specimen and look at it under a microscope. There's bland fatty liver, denoted here on the left-hand side, where there's all these areas of white that are areas that are occupied in the liver with fat, but there's not inflammation and there aren't liver cells dying and scar tissue developing. On the other hand, another subset of patients with fatty liver disease have what we call steatohepatitis. And in this case, not only do they have the fat, seen again here on this slide, but they also have inflammation and liver cells dying. So this is considered, the progressive form of fatty liver disease, both when it's caused by alcohol or non-alcoholic fatty liver disease. Right now in 2021, the best way to discriminate between non-alcoholic fatty liver, or between fatty liver and steatohepatitis, is a liver biopsy. But we're studying many different ways to distinguish between the two non-invasively. When alcohol causes liver disease, it similarly causes fat to develop in the liver. And alcohol-related liver disease is really a spectrum. It can just be simple fat in the liver, as I just mentioned, but it can also lead to really advanced liver disease, including hepatic decompensation and liver cancer or hepatocellular carcinoma. Alcohol-related cirrhosis is unfortunately increasing substantially in people ages 25 to 34 years old. We're seeing that the burden of alcohol-associated liver disease and cirrhosis, which is an end-stage form of liver disease, where there's a substantial amount of scar tissue in the liver, is increasing in this population. Alcohol-related liver disease is often a cofactor with another liver disease, and it makes it hard for us to identify exactly how much of the population is affected. Oftentimes it's viral hepatitis C, but sometimes it's obesity or some of the risk factors for non-alcoholic fatty liver disease that can synergize with alcohol use and cause more insult and injury to the liver. Alcohol-related liver disease, including people who don't have advanced liver disease, may affect around 2% of the US adult population. So non-alcoholic fatty liver disease may affect a quarter of the population, and then another subset are affected by alcohol-associated fatty liver disease. Again, both cause excess fat to deposit in the liver. Both can cause inflammation, scar tissue, and even advanced liver disease and liver cancer. So what are the risk factors for fatty liver disease? One is obesity, and we'll talk a little bit more about that today. Essentially, in the same way that your body can gain weight at any part of your body, whether that be your trunk, your abdomen, or your legs, you can also put an abnormal amount of fat in the liver. And certainly when people gain weight globally, that puts them at risk for gaining weight and fat in the liver. High blood pressure, high cholesterol, diabetes, alcohol use, and the underlying genetics of the patient really are the factors that we consider as risk factors for the development of fatty liver disease. There are other less common causes of fatty liver disease related to medications or other conditions, but this encompasses more than 99% of patients with fatty liver disease. Oftentimes, patients that I counsel and talk to feel as though they can't change the disease that they have or the fatty liver that they have. And here it's important to demonstrate and convey that genetics are important, but that many of the genetic risk factors can actually be controlled with a healthy lifestyle. So I'm going to explain this slide, which is a slide from a study published in one of the premier journals, Nature Genetics. And here the dark blue circles indicate a genetic risk variant. So this risk variant is particularly prevalent in many populations, including the Hispanic community, may have a 30% risk of having this gene, and this gene is associated with a higher amount of fat in the liver. So the light blue is one copy, the dark blue is 2 copies of the gene, and we're looking at how the gene impacts liver fat on this up and down y-axis here at different body mass indexes. So a body mass index of less than 25 is considered normal, not overweight or obese. And here you can even see if you have 2 copies of this gene that puts you at risk for non-alcoholic fatty liver disease, the amount of fat in the liver in this population is still not abnormal. But as you gain weight, you see that the gene gets more power to cause more fat to develop in the liver. So even if you have an at-risk gene, the ability to control your overall body mass index or weight can prevent that from causing damage to the liver. This was published from a European group, and then we recreated this and went further by creating a genetic risk score that looked at many different genes that are associated with fibrosis and cirrhosis in the liver. Here, the blue bar is a group that has a really high genetic risk. So they're at the highest 1 percentile of genetic risk, and we're comparing that group to people who do not have an elevated risk in their genetics. And then we look at the risk of developing cirrhosis at age 75 based on the amount of drinks taken in per week, drinks of alcohol. And these are standard drinks of alcohol. And you can see that as the number of drinks increased, the risk goes up exponentially in those who have a high genetic risk, whereas it goes up in those without a high genetic risk, but significantly less so. But the important factor is here, when we look at the right-hand panel and we evaluate the interaction between body weight, here it's body mass index, and again, as I mentioned, less than 25 is considered normal, and drinks, and we look at the high genetic risk compared to normal. So if your weight is normal and you're drinking less than 14 drinks per week, and this was a large population that we studied, the risk of cirrhosis was similar even if you had a high genetic risk. It's only when you start to accumulate these other factors, including higher body weight or more drinks of alcohol per week, and you move over to this population that has obesity and or a high amount of alcohol intake, 21 drinks a week, and we see that the risk of cirrhosis then increases substantially in the population with an increased genetic risk. So genes matter, and I tell my patients that sometimes we're unlucky and we get genes that predispose us to diseases. But fortunately in liver disease, much of the risk associated with the most common genes contributing to fatty liver disease and cirrhosis can be controlled with some healthy lifestyle factors, including minimizing alcohol and controlling body weight. What do we know about the number of patients and people in the United States that are going to be impacted here by non-alcoholic steatohepatitis or NASH? So this is the progressive form of fatty liver that we'll see most commonly. And these are stages of scar tissue and estimates in the United States in 2015, and then a model predicting what will happen to the country by 2030. And so in 2015, this stage 4 is cirrhosis, and 1.3 million Americans were estimated to have cirrhosis from non-alcoholic steatohepatitis. Many of them may not know because, as we'll discuss, there's no systematic screening for fatty liver disease in the United States in 2021, but may go on to develop some complications of liver disease. We estimate that that number will more than double in 2030 to 3.5 million Americans who have stage 4 fibrosis or cirrhosis related to NASH. And so there's going to be a tremendous impact because a subset of these patients may develop liver cancer or decompensated liver disease and have symptoms from that or need a liver transplant. So we know that this is a significant problem that's increasing over time. We know that there are some factors out of a patient's control and some factors that can control the disease. So what happens once you have fatty liver disease? Are there symptoms? This is a common question, and generally this is considered a silent disease, and that's good and bad. It's good in that our patients aren't suffering symptoms, but it's bad because it limits our ability to identify fatty liver disease earlier on in its trajectory. And so there are non-specific symptoms that often get reported to us in patients with non-alcoholic fatty liver disease. But some of these symptoms may be related to the metabolic comorbidities that come along with non-alcoholic fatty liver disease. So for example, obstructive sleep apnea is very common among patients with fatty liver disease, and it's associated strongly with fatigue. But fatigue is actually the most common symptom associated with non-alcoholic fatty liver disease. It's hard for us to dissociate if that's just the extra fat in the liver that's actually contributing to a symptom, or if it's some of these metabolic comorbidities that are so closely tied to fatty liver disease when it's non-alcoholic fatty liver disease that it becomes hard to distinguish. What's the prognosis? So we know that a quarter of the adult population in the United States has fatty liver disease, but many of those patients and people in the United States will not have the inflammatory and progressive form. Similarly, only a small subset will have fatty liver related to alcohol, maybe 2% of the entire adult population, and only a subset of that population will have progressive disease. So then a subset have NASH, so steatohepatitis, or inflammation and liver cells dying related to fatty liver disease. This may be anywhere from 3 to 10 or 12% of the US population. It's likely somewhere in the middle of this estimate. A subset of those patients will have scar tissue in the liver, and a subset of those patients will develop cirrhosis. And I showed you earlier estimates for how many patients may have cirrhosis from NASH now or in 2015, and the increase that we estimate by 2030. Once you have cirrhosis, there is a risk for liver cancer that's on the order of 2% per year. And a subset of people will develop complications of liver disease and may require a liver transplant, or they may die from their liver disease if they're unable to receive a liver transplant, or if they have other comorbidities. It's important to note, though, that even in this population with NASH, this bigger population, still the leading cause of death is cardiovascular disease. And that's because many of these patients have high blood pressure, high cholesterol, diabetes, and other risk factors for heart disease. Also, there seems to be a potentially slightly increased risk of cancers as well. And so these are the top 2 causes of death in the United States already, and they're still true in this population with NASH. Liver disease moves up to the 3rd most common cause of death, from being slightly below 10th. So it does certainly increase. And as you move across the spectrum and develop more scar tissue in the liver, the likelihood of having liver problems increases. Here we show that as you develop more scar tissue, when we looked at what's associated with dying from liver disease, certainly the stage of scar tissue appears to be one of the most important factors. And it's based on this data that the FDA and most industry targeting treatment of non-alcoholic steatohepatitis, so fatty liver disease, related to not related to alcohol use, are targeting patients who have at least stage 2 fibrosis or greater. Again, if it's really unlikely that someone is going to have liver-related mortality, or in other words, that they're going to die from their liver disease, they may not need a pharmacologic treatment. They still need to focus on sort of how can you minimize the amount of liver fat so they don't progress to a higher stage of liver disease. But the pharmacologic treatment is really going to be focused on this population with stage 2 and higher, who are at risk of having serious consequences from their liver disease. So the next question is, I think, very relevant, and it's going to change, I think, in the next few years. But I'm going to give you current data and my perspective on how I think things may change in the future. So should I be screened for fatty liver disease? We know that certain populations are at an increased risk of developing fatty liver disease. One population is if your family member, or if your 1st-degree family member, had fatty liver disease, particularly fatty liver disease with cirrhosis. As I mentioned, there's a strong genetic component and there's a strong heritable component to fatty liver disease. And in 2021, the liver practice guidelines still recommend against screening family members of patients, or 1st-degree family members of people with non-alcoholic fatty liver disease. We know as liver doctors that there's certainly an increased risk, and that fatty liver disease certainly clusters in families. And so we set out to study this, and we did at the NAFLD Research Center at UC San Diego. This slide helps share some of our results. So if you didn't have any relative, 1st-degree relative with fatty liver disease, your risk of having advanced scar tissue in the liver from fatty liver disease was low, as we expect in the general population. If we looked, only about 1%. If you had a relative who had fatty liver but didn't necessarily have scar tissue or advanced or cirrhosis, then your risk certainly increased substantially. But if you had a 1st-degree family member who had cirrhosis, so stage 4 fibrosis, the most advanced form of fatty liver disease, your risk, and this is a population that didn't know they had any fatty liver disease, was 18%. So really substantial in terms of having already advanced scar tissue in the liver. Now, certainly there are other factors at play here. Age is an important factor. So maybe if the 1st-degree family member is 30 years old, the risk is lower. And if they're 65 years old, the risk is higher. But this is one of the first studies demonstrating how high the risk can be in family members. And in the future, when a subset of the population is screened for non-alcoholic fatty liver disease, I think that obtaining a family history, and if there is advanced liver disease from fatty liver running in the family, then that population may be one to focus on for screening. So as we go back to this is the practice guidelines given by the American Association for the Study of Liver Diseases with regards to screening patients with diabetes. And here again, the practice guidelines say that we can't recommend systematic screening of patients with diabetes. But what do we know? We know that if we look all over the world, this is a summary slide of data from all over the world looking at the prevalence of fatty liver disease if you have type 2 diabetes. It's more than half. 55.5% of people with type 2 diabetes across the world, on average, as we look at all the studies that have been published in this domain, had non-alcoholic fatty liver disease. Certainly that is concerning, and we see it in the United States, we see it in Latin America, in Europe, across South Asia, and in Africa. But importantly, as I mentioned, the progressive form of fatty liver disease, known as NASH, was present in 37% of patients with type 2 diabetes. So whereas I said it was somewhere between 3 and 12% of the general population, that increases substantially in the population with type 2 diabetes. And we know that that is the progressive form of disease. So again, at our UC San Diego Non-Alcoholic Fatty Liver Disease Research Center, we set out to systematically evaluate this. And we started screening people from primary care practices who had type 2 diabetes. And we looked at their risk of fatty liver disease, and it was 65%. So almost 2/3 of the population that was referred to us, our study, that had type 2 diabetes in primary care with no known liver disease had non-alcoholic fatty liver disease. Then when we evaluated non-invasively using some advanced MRI techniques, if they had advanced scar tissue in the liver, 7% of this population had advanced scar tissue in the liver, unbeknownst to them. And this is again in a population with type 2 diabetes. But we have to get a little more granular. Where is the risk really substantially increased? And certainly when we look at this light pink bar looking at advanced fibrosis, the risk increases as you get older. So it's the older diabetic population that is really enriched for having a risk of fatty liver disease with scar tissue that may warrant screening in the future. We're currently conducting a larger study, 5 times the study that with the data that I'm presenting to you now, to validate our findings and to prove in 500 people with type 2 diabetes that there is an increased risk of fatty liver disease and specifically an increased risk of scar tissue related to fatty liver disease, so that in the future there may be screening implemented. So again, fatty liver disease is a silent disease. So how do we identify the people that are at risk for developing complications? And one pathway is looking at some of these simple risk factors that anyone can sort of provide you. So they can tell you if a first-degree family member generally had cirrhosis from liver disease or cirrhosis of the liver. They can tell you generally if they have diabetes, and someone can easily measure their weight. So is obesity a risk factor that we can incorporate in the future into potential screening guidance? It is, and 80 to 90% of patients with NAFLD, so non-alcoholic fatty liver disease, are overweight or obese. Even among that 10 to 20% that aren't overweight or obese, most still have increased abdominal fat. So the distribution of fat and the total body weight may be normal. The total body weight may be abnormal, but the distribution of fat may be abnormal, with an increased predisposition to put fat into the abdomen and the liver. Almost all patients with NAFLD, even if they have a normal body weight, benefit from exercise and weight loss. And we know that the risk of fatty liver, again, in a study that summarizes the risk across the entire world, is strongly associated with caloric intake, although not completely. So even in some areas where caloric intake is less than North America, for example, there is a high prevalence of fatty liver disease. But certainly, this is a significant risk factor. And what else do we know? We know that if you're able to lose weight, that the amount of scar tissue in the liver can substantially diminish. So this is a study of patients from Europe who underwent bariatric surgery. So that's a gastric sleeve or a Roux-en-Y gastric bypass, are the two most common surgeries currently done. And here we see that at baseline, many of these patients have scar tissue in the liver, basically all of the colors that aren't this light beige. Within a year, many more of these patients had no scar tissue in the liver, and now there's substantial subsequent data looking at 5 years out, and this is really a durable and increasing effect on even scar tissue in the liver. So even the most concerning feature that we see in people with fatty liver disease, the amount of fibrosis or scar tissue, can diminish with weight loss. And it doesn't have to be as extreme as bariatric surgery, sleeve gastrectomy, or Roux-en-Y gastric bypass, but any amount of weight loss seems beneficial to patients with fatty liver disease. So how can I treat fatty liver disease? And the backbone of treatment in 2021, and it will likely remain the backbone forever, is lifestyle modification. So this slide summarizes the results of a clinical trial where patients with non-alcoholic fatty liver disease underwent a weight loss program. And here it shows that with the increasing amounts of weight loss, what improved? So NASH is steatohepatitis, or the inflammation and liver cells dying that I mentioned is sort of the progressive form of disease, and it's a target for treatment. If we can improve this, then we can minimize the risk of progression. Scar tissue is what develops in the liver over time when there's been an insult to the liver or something harming the liver. And it's what I showed you was the most strongly associated with dying from liver disease. Steatosis is fat, and this is fat in the liver, and this is sort of the original driver of this process. And so here is how weight loss impacts all of these different factors in the liver. So most of the patients lost less than 5% of their body weight, but still many of these patients had some improvement in the amount of scar tissue or fat in the liver by engaging in this weight loss management intervention study. If you're able to lose more than 5% of your body weight, 5 to 7%, almost 2/3 have an improvement in the amount of liver fat. If you lose 7 to 10%, now NASH resolution, which is resolution of that inflammation and liver cells dying, increases to almost 2/3 for that subset. Then if you move to the group that lost more than 10% of their body weight, 10% or more, you can even reverse scar tissue. And so this is the substantial potential of weight loss. But as you can see, only 10% of patients accomplished this most dramatic weight loss. And this was in a 52-week, really intensive, rigorous study where you're checking in on both your diet and lifestyle regularly. So it's certainly hard. What dietary recommendations should you make or to improve fatty liver disease? Certainly, saturated fat is associated with an increased risk of fatty liver disease and an increase in omega-3 polyunsaturated fats. So this is oftentimes nuts, certain types of oils, and fish that are most commonly high sources of omega-3 polyunsaturated fats. That may also decrease inflammation in fatty liver disease. Sugar-sweetened beverages rapidly get converted to fat in the liver. And so I advise my patients to avoid all sugar-sweetened beverages. And sometimes for patients who were drinking a lot of sugar-sweetened beverages, just that intervention can substantially improve their liver. Fructose upregulates the body forming its own fat. So, you can take in fat, and then the body can also make some fat in the liver. And fructose, which is, again, an ingredient in many of our foods and drinks, can upregulate that. And this has been studied in kids and adults and is certainly a risk factor. Protein improves satiety, so it makes you feel full and helps people maintain weight, but diets that are very high in animal protein are associated with an increased risk of fatty liver disease. because red meat intake is a risk factor. And they may be related going back to higher saturated fat or other factors. Generally, increasing protein is good, but it shouldn't all be animal protein and red meat. The Mediterranean diet has been studied. This is a diet that's high in nuts, olive oils, fresh fruits and vegetables, and some lean meats and legumes. And it seems as though this reduces liver fat, and it's recommended in our society guidelines, but it may not be practical for all cultures. And so we always have to take that into account. And really, it's been studied on a smaller scale. Low carbohydrate and low fat diets have both been studied. Oftentimes patients ask, should I just go on the low carb or low fat? Both have been studied and have had similar efficacy with relation to the fatty liver disease. Fiber intake is protective against non-alcoholic fatty liver disease, and I generally explain it as fiber intake helps slow down also the absorption of foods and sugars, and so the body kind of gets a nice slow intake, and the first stop is the liver. This may help mitigate or prevent the liver from converting a surge of nutrients into fat. Also focus on minimizing sugar, not just sugar sweetened beverages, but any added sugar in the diet. Ultimately, I try to work with my patients to personalize my recommendations for their diet and lifestyle. And just by increasing mindfulness of what we are consuming, many patients make progress in their diet and their fatty liver disease as a result. Importantly, alcohol is a significant cofactor in fatty liver disease. And if you have non-alcoholic fatty liver disease, so related to weight or diabetes, alcohol use, even in moderation, may contribute to worsening liver fat or inhibit the ability of lifestyle measures to improve the amount of fat in the liver. Certainly, if someone has a lot of scar tissue in the liver, which we call advanced fibrosis, that population shouldn't drink any alcohol because it's been demonstrated to increase the risk of liver cancer. In addition, it's not all things that you have to take away. Coffee actually seems to be beneficial, particularly black coffee, and decrease the risk of liver fibrosis. So what treatment options exist in 2021? Well, despite the fact that we're studying so many different drugs for the treatment of fatty liver disease, there's no FDA-approved medication, and there are only a few existing supplements and medications that have been studied and systematically demonstrated benefit. One is vitamin E. It's been studied in the most rigorous way, a randomized controlled trial, and it seemed to improve the amount of liver fat, inflammation, and liver cells dying in this study published in the New England Journal. And it may have an impact on liver fibrosis over time when we looked at accumulation of multiple studies together. There are some small safety risks that I recommend you discuss with your doctor if you're considering it. I don't recommend that people who've been told they have fatty liver just start taking this over the counter, even though it's available over the counter, without discussing the risks and benefits in greater detail, because there are a few minor risks associated with it, and there's only a specific population that it really seems to help. What are additional treatment options? So many of the treatment options that we're studying.
Before you move on, there's a question that kind of pertains right to this. So I don't want to lose the topic that as you're on it. With FO2 fibrosis, is it okay to take dietary supplements for weight loss? Suggestions for specific types like cortisol blockers or certain herbs. I know you passed that, but you're kind of still in that area, so I wanted to put that out there.
Sure. Yeah. So dietary supplements are always they're not necessarily regulated by the FDA. So the exact compounds included and the rigorous study of dietary supplements and their association with weight loss hasn't really been scientifically assessed. And so as a liver doctor, I'm always concerned because at least once a year I see someone with substantial liver injury related to a dietary supplement that's used for weight loss. And so I don't generally recommend any specific dietary supplements for my patients. I'll discuss a little bit later some emerging medications that are strongly associated with weight loss and have a good safety profile, and that just recently obtained FDA approval. And so I think that's more of the best domain and reliable way to focus on weight loss.
Great, thank you.
Sure. So additional treatment options, many of these are actually borrowed from treatments that are needed for other metabolic diseases like diabetes. And so pioglitazone is a medicine that's been used to treat diabetes for decades, and it's actually demonstrated improvement in liver biopsies in randomized controlled trials in people with fatty liver disease. Unfortunately, pioglitazone actually paradoxically causes weight gain. It seems to likely move fat from one place, that it can cause harm like the liver, and it may put it in other peripheral and less metabolically active areas. So for this reason, we often don't utilize pioglitazone, but some endocrinologists or doctors that focus on the treatment of diabetes may prescribe it, and it may have some beneficial impact in the liver. Small studies have demonstrated benefit with liraglutide, which is a medication that's been approved for the use of weight loss, and it's a GLP-1 agonist. And this type of medicine is being studied for its impact in diabetes, obesity, and fatty liver disease. So it kind of hits exactly on the topic that we're here to discuss today, and I'll demonstrate, or I'll share with you some promising results that have recently been published for its impact, this type of medicine's impact on the liver. I'm only going to highlight 2 of many clinical trials in non-alcoholic fatty liver disease, just to show that there is some hope in the pharmacologic landscape moving forward. So this is obeticholic acid. It's a medicine that doesn't necessarily have an impact on diabetes or a substantial impact on weight, but it does seem to, in the treated population, be associated with a slightly increased likelihood of improving scar tissue in the liver. So here we have, one of the first medicines that has been studied in a larger scale clinical trial. This is the interim analysis of the last phase, phase 3, and they showed that almost twice as likely to have an improvement in scar tissue if you're taking this medicine compared to people who are assigned to placebo. So this is one medicine that has some promise. Another that was just recently published, again in the New England Journal of Medicine, which is the among the highest level journals in medicine, is semaglutide. And this medicine is a GLP-1 agonist, as I mentioned before, and it really substantially improves NASH. So compared to placebo, people who were on the higher dose of semaglutide essentially had 3 to 4 times as likely of having a resolution of their NASH. Now, they didn't have a signal here that it clearly improved the amount of scar tissue, but longer studies may be required to demonstrate that. But semaglutide, as I mentioned, and this type of medicine is actually used to treat diabetes and obesity. So what is the impact? We've seen that it can help the liver. How does it help your body weight and your diabetes? And here we see, as you move to the higher dose, these patients had dramatic amounts of weight loss. Here in the highest dose, it's almost 13% of their body weight that they lost during the course of the study, and their hemoglobin A1C, or glycated hemoglobin, which is a measure of your blood sugar in your body over the preceding 90 days, essentially decreased substantially. A 1-point improvement is significant for patients with type 2 diabetes. So the future may have a few factors incorporated in it. For the subset of people where lifestyle modification, changing your diet, increasing the amount that you exercise, for the population where that's not enough and there's still scar tissue in the liver, there are emerging treatments that will likely be beneficial. Some of those treatments may also decrease the risk of or decrease body weight and improve control of type 2 diabetes for the affected population that has those comorbidities. So in conclusion, fatty liver disease affects about a third of the adult population, and that's non-alcoholic fatty liver disease and fatty liver disease related to alcohol. Only a subset of people will develop advanced liver disease. Thankfully, it's a small subset, but it's growing. And the models that we're using are projecting that this will be millions of Americans. It already is millions of Americans, but that's increasing substantially, and maybe 3 to 4 million Americans in 2030 that have advanced disease related to fatty liver. Right now, in 2021, screening is not recommended, but certain high-risk populations have been identified, including people with obesity and those with type 2 diabetes. And I'd like to add also people who have a first-degree family member that have cirrhosis from fatty liver disease. We're doing many of the studies to prove that there will be a potential benefit to screening certain at-risk populations. For example, people with type 2 diabetes that are older than or equal to 50. And there are ongoing studies looking at the risk in the population who are overweight or obese. So that work is being done, and as soon as the data sort of is demonstrated and validated, we're optimistic that we may be able to find people earlier through screening programs. Finally, many of the criticisms of our desire to increase screening is that there's no pharmacologic treatment. But what I've hopefully conveyed to you over the last 30 to 40 minutes is that there are opportunities to intervene with lifestyle measures. There are a few medications that have demonstrated a benefit for those that have biopsy-proven fat and inflammation or steatohepatitis. And in the future, there certainly will be treatments that will help fatty liver disease, and they may also improve obesity and diabetes as well. So with that, I'd like to close and make myself available for any questions.
Great, excellent presentation, Dr. Ajmera. I'm interested when you talk about the lifestyle changes and you showed the graph on the percent of weight loss. Has there been research done on sustained weight loss and the percent that regain weight? And for those that regain, do they gain at a higher percent of fat, or is it the same? So is it worse fat if they regain, or is it just they regain and they start over? So has there been any research on that?
Certainly, you're right, Scott. That's a common issue. So after these intensive lifestyle modification regimens, particularly in the setting of clinical trials, people regain weight as they go back to their regular life, and in regular life, people's weight goes up and down over time. Myself and others, we're doing studies to look at weight loss, weight trajectory over one's entire life and how that impacts the amount and severity of fatty liver disease. But we don't think that it causes a more severe disease if you lose weight and gain weight. There have been studies that have suggested that really rapid weight loss and weight gain may be particularly harmful in people with fatty liver disease, but we're talking about sort of losing massive amounts of weight in weeks, not months. And that's not common unless someone's going on a very extreme diet. And those extreme diets may restrict essential nutrients that the liver and the body needs. So to summarize, unfortunately, a large percentage of patients regain weight after weight loss programs. And it seems as though that goes back to the same risk, not an increased risk of fatty liver disease. That's where bariatric surgery is generally associated with a higher rate of sustained weight loss, although there can be rebound there as well, but the overall impact is substantial. And similarly, we're hoping that some of these drugs can also help and maintain sustained weight loss for people who fail all the other steps, lifestyle modification.
And we've got a couple on the diet aspect. One is the keto diet healthy for those with fibrosis? And then the second one is you talked about genetics, and there's a lot of discussion around blood types and diet. Is there any connection there? So the keto diet or understanding your blood type, would that be helpful in identifying a diet that works best for you if there's a genetic component? Are they not linked together?
Yeah, so the keto diet is interesting. I think that the benefit of the keto diet has been most clearly demonstrated in blood sugar control in diabetes. That's where there's better evidence. I'm concerned about keto diets where there's a high amount of saturated fat intake. So if you're replacing, one bad thing, let's say sugar, with another bad thing for your liver, saturated fat, you may not see the benefit. And so I think that it's I advise patients to go on the diet that is most sustainable to them. But if the diet is the keto diet, then I really caution against having too much saturated fat and red meat intake, because there are studies demonstrating that that is at risk for the liver. That said, for people who can really restrain and adhere to a keto diet that is not high in saturated fats, and they increase polyunsaturated fats or good fats, that can be an option, but it's just uncommon in my practice. And then the second question about blood type and then diet and the impact on fatty liver, that hasn't been established with regards to the impact on liver disease. The genes that have been most strongly associated with an increased risk of liver disease are mainly related to how the body metabolizes fats, and that's what we would expect. And so, and some of them have to do with how the body makes and breaks down scar tissue potentially. So not any data really on blood type, diet, and fatty liver disease. My hope, and a large part of our research program, is that we can make available knowledge about genetic risk of fatty liver disease to everyone. If you order a panel of genetic testing that's commercially available, or if your doctor orders it and can help you interpret it, that it can include the genes that we've discovered and others and their association with fatty liver disease.
Excellent. There's a question that connects something with fatty liver and PBC. It says, do you get increased GTT with fatty liver or just with PBC?
Fatty liver can cause an increased GGT, absolutely. So it's another one of the liver enzymes that can be affected. All of the liver enzymes can be affected with fatty liver disease, including GGT.
And I think to wrap it up, maybe your thoughts on some recent information that came out regarding weight gain during COVID. The average amount of weight gain, they said, was some 29 pounds. Do you think this is a weight that is going to be kind of easy on, easy off once people get back to being active, or could this send us in a direction that your current studies haven't predicted?
Yeah, I think that unfortunately weight loss is rarely easy off. It's almost always easy on and very hard off. I'm hoping that as we move, towards a point where people can be comfortable being more active again, that there will be sort of a normalization of weight. And anecdotally, I've seen that already. Many of my patients have gotten more active again as restrictions have been lifted. I think that it accelerates a trend that we already knew was happening. And there are nice charts that the government showing the prevalence of obesity over time, and we're marching towards just more and more increased weight. And I don't think it's a simple reason. I think that certainly the food is contributing, but there are likely other factors, maybe even changes in our microbiome that are contributing to weight gain over time. And so I think it maybe slightly accelerates the trend that we were already seeing over time.
Okay. Well, thank you for your excellent presentation and for making yourself available tonight. There's a lot to think about, and more importantly, as we work as a community to start collaborating with many partners that you highlighted in your presentation. This is going to be a solution that involves many working together to address it. So thank you so much, and thanks to you who have attended. And watch our website for upcoming webinars, and have a great evening. Thank you very much.
Thank you.